Oshawa. So I don't do much contraception anymore in my practice, but I have done 5 years of OBGYN training where I did do an awful lot of contraception. And I am recently moved to Ontario. I'm originally from Nova Scotia, did most of my training there, and then subsequently went to Winnipeg for my fellowship. So I have not done an awful lot of low resource setting work in Ontario specifically, but working in Winnipeg, we work, I think, with probably a lot of very similar populations with the rural, remote First Nations communities. There's a large urban population in Winnipeg as well, but I did do a fair amount of outreach work to our remote fly-in communities when I was in Manitoba. So I have a good sense of sort of what the setting is like and the style of practice that is possible in those areas. So my plan today is to do a quick sort of overview of contraception and contraception options. And then I'm hoping that I'm not going to take a huge amount of time in the actual didactic part of things. And afterwards, I invite any questions and I'll do my best to answer things as I can. I'm going to attempt to share my screen, so bear with me here momentarily. Can you see? Perfect. All right, so this is, as I said, more of a review. I have to put in my disclosure slide. I have nothing to disclose. I have no financial support and no biases. I've not been working long enough to accumulate any financial support of any sort. So starting with the basics, who is a candidate for contraception? Essentially, any woman desiring control over their reproductive cycle in some way, shape, or form is a candidate for contraception. There's no true age that is too young, no age that is too old. Obviously, if you are premenopausal or postmenopausal, then you don't need contraception. But if you have a reproductive cycle, anyone is a candidate. And as we all know, contraception is very important. In general, looking at Canada-wide data, our rate of unintended pregnancies is 61%, and nearly 1/3 of all women will have had at least one induced abortion. We don't have numbers, at least sort of nationwide, specifically for our high-risk populations or our rural remote populations, but sort of practically and anecdotally speaking, I think we all know that those numbers are likely higher in these women. They're at-risk women for unintended pregnancies. They tend to have fewer resources to access abortion services if that's what they wanted. So certainly contraception is something that's very important in these populations. And at this point, barrier methods tend to still remain the most commonly used method of contraception in Canada. And we know that they have very high failure rates. They're often used improperly. They can break. There's other issues there. So we don't currently have a good handle on contraception in terms of providing it in an easy way to all women. Part of that is because of the counseling and availability, I think. So any time you see a woman of reproductive age should be used as a opportunity for some form of contraception counseling, where if it's just raising the idea or if it's a more in-depth counseling session, any time a woman presents to any sort of healthcare service, it's a good time to sort of bring this up and try and feel out a woman in terms of what she's interested in, what her options might be. There's two sort of large parts that I think are important for counseling regarding contraception. One is information gathering, and then the other is the actual counseling piece. Information gathering includes a sexual history, in terms of what gender a woman might have partners with, what her risk of pregnancy currently is. It's also important if there are any red flags or any suspicions to do some form of an intimate partner violence screen, make sure she's comfortable with her sexual life at this time. STI screening, prevention, and treatment can also be done. And then, of course, fertility planning is important. Not everyone wants to prevent pregnancy, and clearly patients who are interested in pregnancy are not going to be interested in contraception, and that makes your counseling quite straightforward. When you're actually having a discussion about contraception for a patient who's interested, discussing all of the options, the efficacy, the typical failure rates, and the sort of hiccups with use in terms of Adherence and challenges with making sure that the methods are used appropriately are important. And then, of course, discussing the various side effects, because if a patient doesn't know about them beforehand, you put a patient on the birth control pill, for instance, she starts to experience nausea, she's going to stop it almost right away. Whereas if you tell someone you might have a month of nausea and then it'll go away, people are more likely to stick with it and put up with it. So broadly speaking, I was going to talk mostly about hormonal contraceptive methods, but this is sort of a general tree of what is available. So any form of reversible contraception can be either hormonal or non-hormonal. Non-hormonal options include barrier methods or Lark, which is long-acting reversible contraception. And then hormonal can be either short-acting or long-acting. And those are your broad categories. This is a sort of flow sheet that's published in one of the SOGC contraception documents that I think is quite useful. It's very simplistic, but it's a good guide towards what type of contraception is going to be best for a woman. You ask, when do you want to be pregnant? If it's less than a year that a patient's interested in getting pregnant, but it's not quite yet, now is not the right time, then a short-acting contraceptive is a very appropriate option. If a patient doesn't want to get pregnant anytime soon or never, then a long-acting contraceptive is probably going to be the most appropriate choice, and the one that's going to be the least amount of work for a woman and least dependence upon ability to appropriately use that contraceptive method. So I'm going to go through briefly the different types of contraceptions and sort of the pitfalls, side effects, things that might be relevant, things you probably already know, just to sort of have a recap. So short-acting reversible contraceptives, there's progesterone only, and then there's combined estrogen and progesterone. Progesterone only can come in either a pill form, so the mini pill, or the injectable form, which is Depo-Provera. The mini pill is not often used anymore, so I'm not going to spend a lot of time touching on it, other than it's not a particularly reliable form of contraception unless a woman is capable of taking it at exactly the same time every single day with no missed pills. It's effective with perfect use. It's not particularly effective with typical use. So if you have other options, I would suggest using other options. And then I will briefly talk about Depo-Provera. When it comes to combined estrogen and progesterone, the thing that most people are familiar with is the pill. The combinations come in the patch and the ring form as well. I'm not going to specifically talk about them. Overall, the mechanism of action, the side effects, and the contraindications are the same for all of the combined contraceptives. The big difference is obviously how they're applied. So Depo-Provera is a good option for women in whom estrogen is contraindicated. So that would be recently postpartum women, women who are breastfeeding, and smokers who are more than 35 years old. It's also a good option for women for whom taking a pill daily might be a struggle, for whom you don't think you're going to be able to get them back in for a procedural insertion of something like an IUD. It's great for women that kind of come in, show up, you can give them a quick shot and you're done with it. The typical use failure is about 6%, and that tends to come with people who don't return for their next shots. It's also approved for treatment of endometriosis. So if you have a patient that you know who has a lot of pelvic pain, you're suspicious of endometriosis, this is not a bad option. There are some unique risks and side effects to think about. So one is that there is a quite significant delayed return to fertility. So if a woman is actively trying to get pregnant, stops Depo-Provera, they may not return to fertility for up to a year. There is a reduction in bone mineral density, and there tends to be a lot of sort of hype around this. The reduction in bone mineral density that we see with Depo happens while you're getting the shot, and it returns to baseline after you stop taking the medication. You can, however, counsel women to consider getting vitamin D, calcium, weight-bearing exercise, things that you would normally talk about for osteoporosis and decrease in bone mineral density while they're on the Depo-Provera. If you have a woman with high blood pressure, there's a slight increased risk of stroke on Depo-Provera, but not significant. And then the side effects that women will often complain of, it can cause very irregular and unpredictable spotting, and it can be associated with weight gain, which many women are obviously not a big fan of. Practical tips for Depo: there is a higher risk of ectopic pregnancy if a pregnancy does occur. So if a woman gets pregnant on Depo, you need to rule out ectopic. You can start Depo at any point in the menstrual cycle. It does not matter. If it's started within the first 5 days, the contraceptive effect is achieved within 24 hours. So it's better to start it then, simply because then you don't have to worry about alternate methods of contraception to kind of doubly cover, but it's not necessary. And then late injection happens fairly commonly, particularly in women who don't have regular access or challenges accessing healthcare. So the first thing to do is always rule out pregnancy. And then I've listed here a variety of different steps in terms of what happens if you have had unprotected intercourse in the last 14 days or you haven't, how often you need to have emergency contraception or backup contraception. I'm not going to go through it all, but you'll have the slides if you have any questions. This is something that's come up recently in the news. I don't know if you've run into issues with access, but Pfizer is the company that produces Depo-Provera. And Pfizer, as we all know, is currently rather busy trying to produce COVID vaccines. And as a result, they've actually shut down their production of Depo-Provera. At this point, they are forecasting until 2022. So we are anticipating that there's going to be some quite significant struggles accessing Depo-Provera in the future. So if you're seeing someone who, you would normally put on Depo-Provera, but might be an option to have an IUD or some other choice of contraceptive, it may not be a great idea to be starting Depo-Provera at this time because we don't know what the supply is going to look like moving forward. Contraindications to progesterone-only contraceptions are minimal, which is nice. Anyone who has a past history or a current diagnosis of breast cancer, unexplained vaginal bleeding, that's true for any contraceptive because it could potentially be a malignancy. So if a woman has unexplained bleeding, you need to work it up before starting contraceptive. If you have severe decompensated cirrhosis, or if you have some sort of liver tumor, these are contraindications. Otherwise, basically everyone can have Depo. When we talk about the combined options, as I said, I'm basically just going to talk about the pill, but this applies for all of the combined options. The method of application is just a little bit different. So the pill has a typical use failure rate of 9%. We know that in women for whom they move regularly, have disrupted schedules, do not necessarily have a stable housing or home life, that failure rate is higher because they don't have that cue to be taking the pill at the same time every day. And with missed doses, obviously the failure rate increases. The failure rate is also higher in obese women because of the volume of distribution of the drug. It also has a very long list of contraindications, but on the flip side, there's a very long list of non-contraceptive benefits that can be helpful for women as well. Unique risks are blood clot. So there's a 2 to 3 times increased risk of blood clot with the birth control pill. That is typically associated with starting the pill. So that risk does not stay. If you've been on the birth control pill for 2 years and you haven't yet developed a blood clot, you're unlikely to do so. But within the first 2 months of starting, or if you've taken a break and you're now restarting the pill, your blood clot risk is higher. And there's also an increased risk of gallbladder disease, so gallstone formation in particular. Some contraindications that I've highlighted here that might be relevant in our Northern First Nations populations are women who are less than 6 weeks postpartum, smokers over than 35, anyone who has a history of hypertension, vascular disease, history of clot, lupus if they have positive antiphospholipid antibodies, migraines with aura, symptomatic gallbladder disease, so that would be gallstones, diabetes with nephropathy, retinopathy, or neuropathy, people who are on TB therapy, and then there's another incredibly long list that I'm not going to go through here, but suffice it to say there are an awful lot of contraindications to particularly estrogen for the most part that you have to be aware of if and when you're going to start an oral contraceptive pill. Practical tips, you need to use either abstinence or backup contraception for the first 7 days of use because you don't have a contraceptive effect for that first week. You can start it at any point in the menstrual cycle. It does not matter when. The only examination that's required prior to starting is a blood pressure. So you do not need to do a pelvic examination unless a woman has some sort of concern for vaginal bleeding. That being said, if you have a woman in your office and you're starting a birth control pill, it might be a good idea to make sure their pap smear is up to date and their STI screening, if they have concerns, is up to date. The other thing that often I think gets missed is that if you have a woman who's been on a long-term birth control pill and has had no problems and presents with new or irregular breakthrough bleeding, make sure you rule out STIs. 30% of these women are going to have a positive chlamydia test. Now, this is not people who have started a pill and have had continuous breakthrough bleeding the entire time. This is a woman who's been fine and has now developed this in a new setting. It's often not related to hormones, but rather related to an STI. So it's very important to rule that out before you just say, oh, don't worry about it, we'll switch the pill around. This is a chart that's quite useful that I've taken from the SOGC guideline. Again, you'll have it, that basically goes through what to do if a woman calls you or you're speaking to someone who has missed a pill. There's also a website that's quite useful that I've included in the bottom of the screen. This is for patients or providers to use. It's geared more towards patients, but if your patient doesn't have internet access, you certainly could use it for them if they've contacted you wondering what to do with missed pills. And it's just a very good guideline because it's hard to remember all of the timing and numbers of pills and what the recommendations are in terms of, do you just double up? Do you need backup contraception? Do you need emergency contraception? So long-acting reversible contraceptions options are my personal favorite for really any woman. I admit that I'm biased as a gynecologist. I think Lark is absolutely amazing. It is a once and done, incredibly effective. You do not have to think about it once it's in place contraceptive option. There are intrauterine devices, so progesterone containing, which is the Mirena or Kyleena. I'm sorry, I'm using trade names. And then there's the copper IUD. We very recently, within the past year in Canada, have had the implantable device, which is the Nexplanon, approved. There currently is not funding for it at this point, but there is training options and it's coming down the pipes in terms of funding for Nexplanon, which is good. It's been available in the US and many other countries for a long time, and we have not had it in Canada for quite some time. The benefits of Lark, as I'm sure you're all aware of, is it's long acting and it's a one and done approach. So you come in, you have your contraception inserted, typically with an IUD, and you're done. You don't have to worry about it. They tend to have a very low symptom profile. They're incredibly effective. The efficacy is equivalent to permanent contraception. It's entirely coitally independent, so a woman does not need to disclose to her partner that she is on contraception if that's something she's worried about. And it can be used in pre and perimenopausal women at any age. There's no restrictions. So if you have a young teen coming in who is nulliparous, there's no particular reason why you cannot place an IUD. The drawbacks of Lark is, of course, that it requires procedural insertion. Sorry, that's my pager. That it requires procedural insertion, so that, you know, that means that a woman has to have access to and come see a healthcare provider. There's a certain amount of training that's required to be able to insert an IUD or the Nexplanon, and it can be uncomfortable. So those are the main drawbacks. But if you're able to get a woman to access those services and agree to have an intrauterine device or an implantable device placed, the contraceptive efficacy is excellent with very little concern about lifestyle, concerns about adherence, things like this. So a couple of the options. So the copper IUD has been around as an IUD for the longest. Indications, any woman seeking effective, reversible, coitally independent method of contraception. It can also, interestingly, be used as an emergency contraceptive option. It is associated with a slight increase in dysmenorrhea and menorrhagia, so your cycles can be heavier and more painful, which for some women is definitely not something that they're interested in. The unique thing that you can see with the copper IUD is that when you do pap smears, up to 20% will have actinomycosis. You don't have to do anything about this if the patient is asymptomatic. You leave the IUD in place and essentially you just ignore it. You do not have to treat it. If the patient is symptomatic, so pelvic pain, abnormal discharge, rarely you can develop a pelvic mass that might be associated with actinomycosis. At that point, you would consider removal of the IUD and treating with antibiotics. The levonorgestrel IUDs come in, at this point in Canada, two forms. There's the Kyleena, which is good for 5 years, but has slightly less levonorgestrel than the Mirena IUD, which is, they're both good for 5 years for contraception. They can be used for up to 7 years for cycle control, but after the 5 years, they are no longer considered to be as effective for contraceptive benefits. Same indications, any woman seeking effective reversible coitally independent method of contraception. They're also incredibly effective for treatment of heavy menstrual bleeding, dysmenorrhea, and atypical endometrial hyperplasia. The amenorrhea rates for the Mirena are 44% at 6 months. It's going to be slightly less for the Kyleena because the dose of the progesterone is lower, but the cycle will still be heavier. There is a slight increased risk of ovarian cysts. So these are benign cysts, but for women that are prone to cysts or torsion or issues, that may be something to bear in mind. Contraindications to the IUD, whether it's progesterone or copper, or are pregnancy, current PID, and a known distorted uterine cavity. Otherwise, these are incredibly safe and can be given to basically anyone. The breast cancer contraindication, which exists for depot and oral progesterone, is not a category 4 contraindication for the IUD, although some medical oncologists will still be uncomfortable with putting in a progesterone if you have a PR positive tumor. Some more practical tips for insertion and removal that I've found helpful over the years. Ask your patient if they don't have any issues with taking NSAIDs to take an NSAID 30 to 60 minutes prior to insertion. Make sure you do a bimanual examination beforehand. I find sometimes we forget to do that, or I forget to do that, and then you're mucking about realizing that you don't actually know what way the cervical canal is going, and you don't know why you're struggling, and you have to remove everything, then do your exam, and then put the speculum back in. It doesn't make you look particularly good. So do your bimanual examination first. If this is a patient's first insertion, make sure you sound the uterus before you open the IUD package. I've also made that mistake. If you do not do that and you are unable to get the sound in, you have now opened an IUD package and you cannot place it, and you have wasted that IUD. They will typically replace it for the patient, but still it's a pain, and it's better to just not have opened it. If you're struggling, putting a single tooth tenaculum on the anterior lip of the cervix to gently straighten it can be incredibly helpful. And if you do all of those things and you're still unsuccessful, sometimes attempting while a woman is on the menstrual cycle can be more successful because there's a little bit more cervical dilation at that time. It's obviously a bit more challenging to see depending upon how heavy a woman's cycle is, and some women are not very comfortable with an examination on their menstrual cycle, but it can be a more effective way of getting the IUD placed. The other thing that you can run into with the IUD is issues with removal. So if you can see the strings, just yank on them. You're not going to invert the uterus if it feels a little bit stuck. So just pull firmly if you feel resistance. If there are no visible strings, you've got a couple of options. If you still have the cyto brushes from when we used to do pap smears with the spatula and the cyto brush, they are an excellent tool. You pop them in the cervix, twirl them around, pull them out. They typically will bring down the strings for you if the strings are just tucked up in the canal. If you don't have a cyto brush, you can try one of the long cotton swabs. Not quite as good, but it will still often bring down the string if it's just tucked up in the canal. If you have IUD hooks, you can use them. I think they're horrible and they cause a lot of pain and bleeding. If I'm not being successful with either a cyto brush or a cotton swab, I will often try personally with a long packing forceps if you happen to have one, and you just gently insert it and kind of close it within the canal and see if you can grab something. If there's no visible strings, you've tried all your tips and tricks and you have no success, unfortunately, you do have to get an ultrasound scan to make sure it's actually in the uterus. If it is in the uterus, you can bring them back and try again, or if you're not successful and it needs to come out, then referral for procedural removal is likely going to be what has to happen, unfortunately. So the new player in town is the Nexplanon, which is the etonergestrel implant. This goes in, as you can see in that picture, it goes in the sort of subcutaneous tissue of the arm. It's insertable in clinic. It's fairly straightforward. I've included some links here about training and how to get training. Right now, because this is new, the company, you can sign up and they will provide training videos, and for free they will send you a practice applicator kit and a dummy arm so that you can learn how to do these things. It's basically like a little kind of like a little gun that shoots it in, and it will walk you through it. You can get trained so that when this is covered, you would be able to offer this to your patients. It provides a contraceptive effect for 3 years. The contraindications are similar to Depo-Provera, so essentially severe hepatic disease or current or past history of breast cancer. As I said, it's not currently funded by OHIP or NHIB at this point, although that is, I expect, coming. The Nexplanon, I think, is going to be an absolutely wonderful option for our women who struggle with accessing healthcare, who have difficulties with examination, who have had sexual trauma that mean that, a speculum examination or an IUD insertion is not possible. I think this is a very, very good option. It's been used in many other low risk settings. There's a gynecologist that's quite well known, who works in Haiti, who has piloted essentially a Nexplanon product where he goes into schools um, and puts in all of these implants into girls that are willing to have them, and it's made huge improvements in terms of the lives of young girls and women and their ability to maintain their independence and not have unintended pregnancies. And there's a lot less fear from particularly young women about having this placed because it does not involve an examination. So I would strongly encourage those of you who are interested in women's health and are comfortable with procedural type things and have been using IUDs to go on the website and get yourself trained so that when this becomes an option, you will be ready, or like a funded option. It's an option now if you have a woman who can pay for it, but I think it's around $200 to $300 right now. But I think it's a great option. As a heads up, women can develop really quite a dramatic bruise at the insertion site, like really large and ugly looking. Doesn't tend to be particularly painful and it's nothing to worry about, but you need to make sure that you warn women that that can happen because it can be very dramatic if you're not expecting it. I thought I would talk just very briefly about emergency contraception because this comes up and it's not something that we think about very often, I'm sorry. So there's a couple of different methods. There's Plan B, which is available over the counter. You can use it up to 72 hours after unprotected intercourse. And then there's the USP regimen, which people are a little bit more familiar with. This has been around for a while. If you have a woman who's on a birth control pill, or you're seeing a woman and you have the ability to prescribe a birth control pill, essentially the easiest way to do it is to take 5 Aless tablets by mouth every 12 hours for 2 doses. So that's a total of 10 Aless tablets in 24 hours. The problem with both of these methods is that, unsurprisingly, it causes quite significant nausea and vomiting. So a lot of women will unfortunately vomit up the pills, making it somewhat less effective, obviously. You can also have a postcoital insertion of a copper IUD. That is a bit trickier, obviously, because it requires a woman coming in to seek healthcare attention and being able to have access to an IUD and the willingness to have it placed. You do require a negative pregnancy test first, but you can place this up to 7 days following unprotected intercourse, and you then will have ongoing contraception moving forward, which is a benefit. One of the things that's good to know is women who have normal contraindications to estrogen or any hormonal contraception can still use hormonal emergency contraception because it's such a short time frame and the dose is low enough that it's not likely to cause a problem. And regardless of what type of emergency contraception you're using, a woman should still have a pregnancy test somewhere between 21 to 28 days following administration. So that's sort of the end of my contraception spiel, and I'll happily take any questions. These are a couple of resources that I've put in here for you. The top two, the for patients resources, are designed for patients, but are also quite useful. I think for practitioners as well, particularly if you're not continuously doing contraception, like if this is not what you do all day, every day. It's a plan is a counseling guide that goes through the different options of contraception. It has a patient questionnaire at the back that is designed to be given to a patient to fill out, which that might not always be practical, but it does sort of point you in the direction of what contraception might be most appropriate for different types of patients. So it's useful in that way. The sexandyou.sos, that's the website where if you've missed pills or you have questions about, taking them at the wrong time, a woman can go to that website, or if they don't have internet access, then, a healthcare practitioner can use it just as easily. And then of note, there is a compassionate contraceptive assisted program, which is available to SOGC members and healthcare providers. And they have basically all forms of contraception that they will provide free of charge if funding becomes an issue. I'm not sure if Nexplanon is on there at this time. This particular program runs on kind of a first come, first serve basis. So they have X amount of each type of contraception that gets renewed, and then that gets renewed annually. And once that supply is out until it's renewed annually. So I do not know if Nexplanon is currently available through a compassionate program. I did sort of do a little bit of research to see whether the drug company themselves had a compassionate program so that you could potentially get access to this for your patients right now. At the moment, as far as I can tell, they do not. So I think Nexplanon is a little bit on the back burner unless you have patients that can afford it. But for most women in low resource settings, they're not going to be able to afford $200, $300 for a progesterone implant for contraception. So I think at this point, that's going to be on the back burner. But once the funding comes through, I do think that's going to be a very, very excellent option for our patients. So I will stop talking at this point and invite any questions if there are any.
Yes, I do have a question. If someone gets pregnant on an IUD,
Yes.
do you guys typically take them all the time? And I'm talking if you can see the string and if you can't visualize the string.
So it kind of depends upon where you are in your pregnancy. So if you're early in your pregnancy, we do typically take the IUD out. The risk, of course, and you have to counsel your patient about this, if this is a desired pregnancy, the risk of removing the IUD is that you could disrupt the pregnancy and that could lead to a miscarriage. If that's not a particular concern for someone, like if they're planning to have a termination or something like that, then I would just sort of leave it in place. But we do often remove them. There is just the risk of a spontaneous miscarriage associated with that. Leaving them in place doesn't really cause any problems. The issue is, particularly if you can see the strings, it can be a source of infection during the pregnancy. Theoretically, it can disrupt the pregnancy later on and lead to, preterm rupture of membranes, complications like this. But if you're not comfortable or you cannot see the strings, there's nothing really extra to do. Like, you don't need to worry about the fact that the IUD is there. We've all seen that picture on the internet circulating of the baby clutching the IUD in its fist when it was born. Like, we see that not uncommonly. I've delivered a couple of babies where the IUD was implanted in the placenta. Things develop normally. It's not teratogenic, but we do still try and remove it if possible.
Thank you.
Mm-hmm.
Thanks for the presentation, Dr. Roberts. That was really great. I just wanted to ask you and just sort of alert the group about this. I guess Pfizer has announced that they will stop making Depo-Provera to focus on making more COVID vaccine.
Yeah.
So this will have huge implications for our client population. because
Yeah.
I'm looking at our utilization data. We're using about 9 of these vials per 3 months period. So I just wanted to ask your thoughts about how do we switch patients over to something else, because that conversation needs to happen as we plan. Um, from a pharmacy perspective, we are trying to beg Pfizer to give us the allocation that we need for our patients, because this is our historical use, but nobody's responding to us. So I kind of have to think of what do we do as a group to alert our prescribers of this possible result, where we have to look up at plan B of giving
Yeah.
something else.
And it was interesting because I had kind of heard this through rumor that this was happening, and I wanted to confirm it before I, came and talked and said this was happening. And it's very difficult to actually find any information about the fact that they have discontinued making this. It is not well publicized, which I think is quite interesting. In terms of other options, I mean, I would suggest trying to transition a patient to some form of Lark if possible. I mean, obviously utilize what Depo-Provera shares you have left. And I would, as I said, I would suggest, if possible, not starting anyone on Depo, and so that the women who are currently on Depo and have been maintained can continue on their Depo-Provera. And if you have patients who are coming in need of contraception, if possible, talk to them about, IUD placement. Hopefully the Nexplanon will come through sooner rather than later, because I think that's going to be a much easier sell to patients rather than an intrauterine device. But it's going to be a major problem. And I think our low resource settings, whether that's in more remote communities as you are versus, our urban homeless communities, are also going to struggle, because it's the same thing. They come in, they get their shot, they go away. We use a lot of Depo in those situations, and it's easy to administer. It doesn't require a lot of training, and it's quite discreet for these women. So that there isn't really an easy replacement, honestly. So it's going to be a lot of, I think, discussion and awareness, and it needs to be done based on, ideally as early as possible, starting the discussion about what the best alternate option is going to be, and trying to mitigate situations where we run into being unable to provide any sort of satisfactory contraception to patients. In terms of a more practical kind of medical thought of making sure you have continuous contraception when you're switching from one modality to another, one of the resources that I'll send you has a large table in terms of making sure your contraceptive effects kind of overlap, so that you don't have a gap in them. And there, you can do that for any transition to any type, whether it's Depo to a pill, Depo to an IUD, all of these things. You can make sure that your contraception overlaps, so that you don't run into gaps and unintended pregnancies in that time. But yeah, it's not a good situation, unfortunately.
Thanks very much. I just have one follow-up question, is with this Nexplanon, which you presented. I know very nothing about it until today, so thank you for raising that. So I just want to make sure I understood correctly that with these implants, once it's in, it's good for 3 years. Is that right?
That's correct. It's like the IUD, where if it's in there for longer, it's likely still going to do something, and it's not going to cause you harm. But the contraceptive efficacy that's been studied and that the product is approved for is 3 years.
Okay, thanks. I'll alert that to our NIHB colleagues, just to say, if we're having issues with getting Depo-Provera, and we are having problems getting it right now for some nursing stations. That's why we know that something is being halted, and Pfizer's protecting that supply.
Yeah.
But it is happening. Like, we can't get the products the way we used to. They're capping it at 1 or 2 vials, and some places may need like 5, 7, 10 vials.
Yeah.
So it's happening. So I'll definitely alert our NIHB colleagues.
And it might be a very good a good bargaining point. I mean, obviously it's not a good thing that Depo-Provera is being held back, but it may be a good bargaining point to get the Nexplanon approved for funding.
Thanks very much.
Hi, can I ask a little bit about women with migraines with aura?
Yeah.
So when you sort of do your history and you're talking about sort of what that would look like, and they say they think they have those, or they know they have those, like there are progesterone only options, but for women
Yes.
who don't want, like they don't want depot, and you're saying that the progesterone only pill is sort of acceptable, but not really a great option.
I mean, if you've got a woman that you can absolutely count on is going to take it at the exact same time every day and never miss a pill, it's a perfectly fine option. But that's a hard thing to do.
So is there, like I've heard some people talking about sort of risk benefit discussions and sort of low dose estrogen pills.
Yeah, I mean, I think if you're using one of the lower dose estrogen pills, all of those side effects and contraindications are related to the estrogen for the combined pill, or almost all of them. Um, and migraine with aura is one of those funny things, because for when they say migraine with aura on the contraindication, they really do mean like you have the full blown like aura where you know your migraine is coming on because you have some sort of sensory disturbance, and like you get the flashing lights and you're seeing things or whatever your aura happens to be, but it's like a true quite significant aura, which not that many people have. And I found when I was doing this more regularly, I would have a lot of women that would answer yes to that question and say, oh yes, I absolutely get migraines, and I get a little bit of spots in my vision. And if you had other options, you just wouldn't use the birth control pill because it was easier. But I mean, if you have a woman who has migraines and is kind of like maybe has a little bit of visual spots every once in a while, but doesn't truly have the pre-migraine sensory disturbance that predicts the migraine that keeps going on through, I think it's reasonable to use a low dose oral contraceptive pill, with the sort of caveat to these patients that there may be an increased risk of complications, but those risks are very low. So I think if that's going to be the only form of contraceptive a patient will take, it's definitely better to be on a contraceptive than it is to have an unintended pregnancy in terms of risks and benefits, because pregnancy is not a low risk state for women with migraines with aura either, because of course the concern is for stroke or clots in the brain in these situations. And so the risk of that with pregnancy is much higher than the risk with a birth control pill, even if you have migraines with aura. And a lot of the contraindications for the birth control pill are broken down into category 3 and category 4. Category 4 are the patients where you just absolutely should not give it. Category 3 is the patients where it is a risk benefit discussion. And if there's no alternative option that works for the patient, and the option is unprotected intercourse with high risk of unintended pregnancy versus accepting a slightly increased risk associated with the medication, I think it's very reasonable to go ahead and give the medication. And migraine with aura, for the vast majority of people, falls into that category.
Thank you. Are there any other questions out there for Dr. Roberts? Any sort of things that have come up in your practice in the nursing station, questions?
I have a question.
A quick question for you. How many pills a patient can miss if they are on a 28 cycle contraceptive oral pills? And say, for example, if a woman misses about 2-3 doses, can she take it all at once on the 4th day? Thank you.
So it very much depends upon when a woman misses her pills, because the effective missed pills differs based on where you are in your cycle. If you've missed more than 2 pills, the sort of standard recommendation is that you need backup contraception. And if you've had unprotected intercourse, particularly if you're in your fertile window, then you may need emergency contraception. Taking all of the pills on the same day, you can do, it's not going to cause harm, but you would still require backup contraception, and depending upon the timing in the cycle, emergency contraception. There, in one of the documents that I'll send you, as I said, there's sort of an outline for what you do with a certain number of pills based on when they were missed and how many pills were missed and what the recommendations are, because it is very much variable in terms of when it is. And in all honesty, I can't remember it all off the top of my head. I used to have to look it up every time just because it changes. So that the website is the SexandYou/SOS, and then there's also a table in one of the PDFs that I'm going to send to get distributed out. So if you have questions, you can use that as a resource and look it up there.
Thank you.
Hello, I have a question.
Mhm.
It's about emergency contraception. Sometimes when we're up north, like there's certain, like some women don't want to take regular, oral contraception, so they come in quite frequently for the Plan B, like 10 times a year, like quite
Oh my
frequently.
goodness.
So I'm
Yeah.
just wondering, like, and sometimes I'll come twice in a month. Like, is there any harmful effects of giving this so frequently? You try and encourage a form of birth control, but they refuse and just keep showing up. So I'm just wondering, like, if that's harmful to them.
Not as far as I'm aware. I mean, it's not common enough that we have good evidence to say one way or the other, right? So it's sort of based on common sense. They're basically the same medications that a person would be taking with a birth control pill, just kind of really high dose quite quickly. So there should be no impact long term on fertility or their cycles or things like that. It's obviously not the safest or most effective choice for preventing pregnancy, but as you say, if women refuse everything else, then our hands are kind of tied. So I think if they're coming in for the emergency contraception, even if they're coming in twice a month, every month for a year, I think it's safe to do that. You're not going to do them any harm by giving the emergency contraception. It's not the best choice, but if that's the only choice you have, then I think it's probably the best thing to continue doing.
Okay, super. Thank you.
Mhm.
Okay, we have a couple more minutes. I'll just leave it open for questions. I just want to ask, the evaluation has been posted in the chat, so if you could take a chance to go in and have a look and complete if possible. Again, the presentation and the recording will be posted to that MSERS website. And while we're waiting for questions, next week we will be a case for reflection and learning for those who can attend.
While I have you here as a captive audience, I am doing, I believe, a pap smear talk in a couple of weeks. And I was just wondering if there's anything in particular that was that people wanted me to talk about, or if it was mostly just an overall review. I'm happy to target it if there was something in particular that was a common issue that came up. I just didn't receive an awful lot of guidance about what you were looking for with that one.
In addition to reading pap smear results and so forth and what to do, I think a common one would be when to do pap smears during pregnancy.
Okay.
If get some guidance on that. And another guidance is the different instruments that we have for collecting pap smear tests. So we still have that spatula that we're using.
Okay.
We use the actual brush part of it as much. And we also have that blue broom.
Yes.
So some guidance into when to use those and so forth too, it would be good.
Sure. Okay, I can do that.
Maybe can you just add some slideshow, like pictures of like abnormal cervixes and kind of what they are and things like that? Because sometimes you go in, you look and you're like, huh.
Yeah,
What is
absolutely.
that? Yeah.
I have an entire collection. My iPhone is a scary place.
Okay, thank you.
So the week before you do your PAP presentation, we do have Cancer Care. They're for Northwestern Ontario coming to talk about the new guidelines
Okay.
And about how to actually do a PAP.
Okay.
So some tips and tricks on how to do it. So yeah, if we could sort of, like all these other things seem to build well on that.
Okay. Yeah, I can do sort of in pregnancy stuff because they probably won't talk much about that, and I'll have a picture gallery that we can go through, and I'm happy to answer any questions. I'm at this point in my training much more knowledgeable about pap smears and funny looking cervixes than I am about contraception. So.
And
there's no, I was just going to say in the chat, there's some tips for finding the cervix and discuss prolapse and implications.
Oh yeah, that's a pain for sure. Okay.
And can you also add to about bimanual exams, when to do them, when not to do them,
Yes,
and so forth?
Absolutely. I'm just going to write all this down, but yes, absolutely, I can do that.
Okay, that's fantastic. We really we appreciate the time, and we appreciate your sort of seeking guidance on our needs for the next presentation. That's fantastic. So if there's no other questions, then maybe we will end for the day. And yeah, we look forward to seeing everybody next week. Thanks for tuning in. Have a great day.
Thanks very much for having me.